sciences. Core ethical principles, autonomy, obligations to respect patients as individuals, that's truth telling and confidentiality, to create conditions necessary for autonomous choice, informed consent, and to honor their preference in accepting or not accepting medical care. That's pretty straightforward. They have the right to their own body, kind of thing. So they need to know everything about what's going to happen to their body when you're treating them. Beneficence, that's physicians have a special ethical fiduciary duty to act in the patient's best interest, may conflict with autonomy, and informed patient has the right to decide, basically, okay, or what is best for society. For example, mandatory TB treatment. Traditionally, patient's interest supersedes. Non-maleficence, do no harm, must be balanced against beneficence. If the benefits outweigh the risks, a patient may make an informed decision to proceed. Like most surgeries and medications fall into this category. Because surgery, you're cutting into them, right? So, but you're doing it for their benefit. So, justice, to treat persons fairly and equitably. This does not always imply equally. For example, triage. We have decision-making capacity. That's physician must determine whether the patient is psychological and legally capable of making a particular healthcare decision. Note that decisions made with capacity cannot be revoked simply if the patient later loses capacity. Intellectual disabilities and mental illnesses are not exclusion criteria for informed decision making unless the patient's condition presently impairs their ability to make healthcare decisions. So capacity is determined by physician for a specific healthcare related decision, for example, to refuse medical care. Competency is determined by a judge and usually refers to more global categories of decision making. For example, legally unable to make any healthcare related decision. Four major components of decision making: understanding, appreciation, reasoning, and expressing a choice. So there's like a question about this person who's above the age of 18 or 21, and then they ask you, you're trying to give them administer a drug, but then they refuse to take it. So what do? Do you continue to do it, or do you ask for help or from their parents or something like that? You don't administer the drug because they are capable of making their own decision, and intellectual disabilities and mental illnesses are not excluded from this. Right, kind of like that. So the question would, they still have the right to make decision. Basically, they still have the right to make decision if they wanna be treated or not. So what this is saying is whether the person, whether the patient is psychologically and legally capable of making a particular healthcare decision, right? In this case, the healthcare decision is if they want to take a drug that treats something, right? And now we're dealing with a Down syndrome person who's an adult. So if he doesn't want to take it, do we still give it to them because they're mentally disabled? That's what this whole thing is about. So if they refuse, you don't force it, right? You should never force anything. There's another one as well, like mm-hmm. Yeah. Mm-hmm. Yeah. Mm-hmm. Right. But then they're under the influence, right? Then they don't have the capacity if they're under the influence. But under influence is different than mm-hmm. Right. Okay, so basically what you're saying is a person who was vomiting and all that and refused to go to the hospital, so then they didn't take him. That's what your question is, right? And yeah, so in this case, what needs to happen is you gotta wait it out until he's unconscious, and then you would like, unless he has stated that even if he falls and gets unconscious, you shouldn't take him. Uh, then you don't do it even after he falls. Then someone else has to make the call, and then they can take him, because they have been told directly by the person what his wishes were, right? And we gotta respect that. But if he was under the influence, that means he doesn't have the decision making capacity. Okay, but that doesn't mean if the person was drinking, he doesn't have the decision making capacity. He still does, because people still are able to function normally most of the time with a couple of drinks, right? So that doesn't mean they don't have it. The times they don't have decision making capacity is when they're like uh, in decay, or they're confused. uh, they're going through the 4 stages of alcoholism or something like that. They're ODing. They're on drugs that changes their mental capacity to understand or verbally communicate what they're trying to say. These are going to be your decreased decision making capacity. But it's a couple of drinks that doesn't decrease it. If the person has Down syndrome, that doesn't decrease it. Uh, if the person is coughing and dying, but he's still telling you he doesn't want treatment, he has that right to tell you that. Okay. Uh, okay. See, this thing is, normally the patient is gonna come to you to the hospital, right? Because when you're outside of the hospital, you don't have you know a liability to help someone. So it's up to you if you want to help or not. And if you do help, there is a law that protects you from any kind of lawsuits, even if the person dies while you're helping. I think it's like, what was it? Samaritan law or something like that. So that will help you in that case. But this decision, you don't have to make it. The only times you will have to make this kind of decision is when the patient is in under your care, and he's already told you his wishes. Most of the time, it's gonna be, and in other cases, what's gonna happen is, they have loved ones, a spouse, right? There's a whole line of people you talk to. First comes the spouse, then the children, then the parents, and then the siblings, and then friends. That's how the decision making goes. So if the person is not capable of making decisions, then you talk to the spouse and ask them what this person would have wanted. Not what they want, but what the person would have wanted. Cool? So let's go through this again and see if it makes sense. So it's just this part that messed you up, right? Intellectual disabilities and mental illnesses are not exclusion criteria for informed decision making unless the patient's condition presently impairs their ability to make healthcare decisions. So this is the main thing, right? If they can understand what you're telling them and you're able to communicate the informed consent to them and they understand it, then it's they have the decision making capacity as well. Then it's their right to refuse treatment if they want to. The only time they don't have it is like where was it, TB. Then you have to like kind of force them to stay in the hospital, right? For the benefit of society. But yeah, this is only time it's going to be, it's like when they come to you in the hospital. You're now going to have to deal with someone at the ambulance site, because that's for paramedics. You don't have to worry about that. 4 major components of decision making is understanding, appreciation, reasoning, expressing a choice. Okay, so they gotta understand. Yeah. Normally, this is never gonna be the answer in this on the steps. You never involve third party. Like there are going to be answers including, you ask the board at the ethics board, you ask the council, you ask the judge. These are not going to be the answer most of the time. Majority of the time, that's not what they're testing. They're testing your knowledge about what you're going to do in these cases, right? They really believe if you're dealing with a patient, you need to, see it through, kind of thing. So when you would involve the judge, what they say. Let's do that. So competency, that's what it is, right? If you're still doubting that they don't have the ability and they're intellectually disabled, and this is a good thing for them, but you can make a case that they don't have the decision making capacity, but then in the future they can come back and sue you for it. So to cover your ass, you're going to go to the judge, and the judge will tell you if he's capable of making this decision or not. And then if he's not, then they appoint someone, a third party, to make decision for this person, and then you go from there, kind of like that. So 4 major components of decision making is, they have to understand the informed consent, the appreciation, like they understand how critical it is to get this treatment, the reasoning why it's critical to get this treatment, and then expressing a choice if they want to take the treatment or not. Yeah. So what is informed consent? That's consent. That's a process, not just a document or signature, that requires disclosure. Okay. A process, not just a document or signature. So a process that requires disclosure, which is discussion of pertinent information, including risk and benefits, using medical interpreter if needed. Okay. Then you have understanding, which is the ability to comprehend, the capacity, ability to reason and make one's own decision, distinct from competence, a legal determination. And then you have voluntariness, freedom from coercion and manipulation. So patients must have comprehensive understanding of their diagnosis and the risks, benefits of proposed treatment and alternate options, including no treatment. Patients must be informed of the right to revoke written consent at any time, even orally. Exceptions to informed consent, wipe it away. So these are the times you don't have to give an informed consent. It's implied kind of thing. So maybe a waiver, someone comes in the emergency department and they're you're trying to explain that you had to cut through their throat to put in a pipe or something like that, right? Because they're going into asphyxiation or something, but they're still capable of making the decision. So then they can just say, yeah, just do whatever you need to just make me feel better, That's a waiver. So patient explicitly relinquishes the right of informed consent there. Okay. Then you have legally incompetent. So this is a patient that lacks decision-making capacity. So obtain consent from legal surrogate. So the legal surrogate is going to be appointed by the judge. That's what you were asking for about over here. The third party, the judge hires that, or they already have someone hired already from before. Then you have therapeutic privilege, withholding information when disclosure would severely harm the patient or undermine informed decision-making capacity. Okay. So withholding information when disclosure would severely. So this is when, like, say you have a grandma, right, who's like 80 years old, and you did some tests and you found out that she has something terminal, and when you did the test, the grandma said that, okay, don't tell me the results. You can tell my granddaughter or something. And so what do you do when the results come? Do you tell them that, yeah, but you need to know because this is terminal. You need to know what's going to happen, right? But then you tell the daughter tells you, yeah, she's not going to be able to handle this news. So don't tell her the results. That's it. So what do you do? It's up to you, right? No, it's not. They already told you that they don't want it. And also the step or like granddaughter told you that this information can give her, I don't know, a heart attack or something. So that would be a therapeutic privilege. So withholding information like that she has cancer or something, or it's terminal, when disclosure would severely harm the patient or undermine informed decision-making capacity, right? And then you have emergency situation. This is implied consent may apply. So, okay, so the thing I said about waiver applies here as well. Okay. Here they can just tell you, yeah, just, it doesn't have been an emergency condition. It can just be, yeah, doc, just don't worry about anything. I'm with you, just make me feel better. Over here, maybe they're not able to talk. So if they're coming to emergency department, on the grounds of emergency room, you have implied consent. Implied consent is, it just means that this whole thing, you can bypass it. So you already told them everything, they understand it, and they're ready to accept whatever you want to do to them. That's what it means. Yeah, he's unconscious. Yeah. So, because normally someone else, a third party or a bystander is going to call 911, right? An emergency ambulance comes and picks them up. Sometimes no one's with them to communicate stuff. So when they come to the emergency room, it only applies to emergency situations, right? So it's going to be in your ER. So the emergency department, right? So that's the only time you have implied consent. So you can cut it through their throat and then put in the pipe without having them sign a paper or something. That's what it means. Because normally for something invasive you need to have the informed consent. And informed consent is just a signature to tell you that cover your ass, that you're not liable for anything after you have explained all the risks and benefits of this. Because it's not just benefits, you're telling them the risks as well, that they could die or they can lose a limb or something like that. So that has all been told to them, and that's part of informed consent. And then if they do lose a limb, they can't, they might come and sue you, but you're covered, so you won't have to pay them. Okay, so there's a doctor who told us about this, that there was a person a doctor who had a patient, and he told them that if we go ahead and do this procedure, you're going to have this side effect, this side effect, this side effect, this side effect, and this side effect, right? But then Yeah, so he named all these, and then they went ahead and did the procedure, and then the person started having one of the side effects after like a month or something. The person started having gangrene on the foot, right, or something like that. So then he comes and sues the doctor, and the doctor, when he was listing out all the side effects, he didn't write gangrene on the side effect, or he didn't explain gangrene or something, right? So then he was sued, and then he was liable, and he had to, you know, pay the person. So to overcome that, you don't list out every single side effect of the thing, because that's impossible to remember or communicate. So all you write on the paper is all the side effects were explained. That's all you write. So then, because the patient's not going to remember all the side effects, because even you yourself don't remember them, right? So that's how you cover that. So this is just like one way of covering your ass in informed consent. I'm not telling this is what you should do, obviously, but it's just a story. Okay, next. Consent for minors. A minor is generally any person less than 18-year-old. Uh, Parental consent laws in relation to healthcare vary by state. In general, parental consent should be obtained, but exceptions exist for emergency treatment, for example, blood transfusions, or if minor is legally emancipated, right? So that's if they're married or self-supporting or in the military. Okay, so a minor is generally anyone below the age of 18, but they could be legally emancipated if they're married, self-supporting, or in the military. Okay, so parental consent laws in general says in general parental consent should be obtained, so that's important. However, there are situations when this does not apply, and these are the situations. So situations in which parental consent is usually not required. Sex, so sex, drugs, and rock and roll. That's how it goes. So when you say sex, what they mean is contraception. So if a minor comes and she wants a prescription for birth control, there's a very controversial topic at the moment, but yeah, contraception. You can give it to them without the parental consent. STIs, venereal diseases. So you can treat it without parental consent. Prenatal care, right? That's if you have a teen mother. Usually not abortion, because again, controversial. Then drugs, substance use disorder treatment. Usually they don't test you on this, they'll test you on these. But drugs, like you'll have a mother concerned of this person because he's been not himself, like this teen who's not been himself, right? He's sitting there in the office and he's not looking in your eyes, he's just, all chilled out. And then you see a little bit of crusting under the nose. So that's one of the questions. What's wrong with him? So does he have autism, or is he on the spectrum or something, or what is it? So it's usually he was huffing something, when you put you put a substance in the paper bag and then you just breathe it in. So that's called huffing. It's usually handkerchief dosed with petroleum or glue or whiteout, something like that. That's usually the things that kids do huffing with, I guess. I don't know. So yeah, but you can treat drugs without the need for parental consent. And rock and roll, emergency again. If you have a kid coming into emergency, you have implied consent anyways, or trauma. Physicians should always encourage healthy minor guardian communication. So even though you don't need it, you should, recommend that they are involved in the decision making kind of thing. Uh, physicians, physician, physicians should seek a minor's assent. So agreement of someone unable to legally consent, even if their consent is not required, right? So this is when you have a child, like a 7-year-old or a 13-year-old, who's going under chemotherapy or something, and you have the parental consent, but so when you go to, IV them, the kid doesn't want you to do it. So what do? Do you just go ahead and do it even though they don't want it? You ask the parents to hold them down? No, that's never going to be the answer, right? You never force treatment on someone. So what you're going to do is you ask them for their assent, and that's where the question will end, because we don't know what we do after that. We're going to step one at least. And assent is just an informed consent, but for minors. That's what it is. And after you tell them everything, hopefully they give you the assent, and then you can go ahead and treat them. Because if you talk to the parents only and not the child's going to be wondering like what's going on, kind of thing, right? So it's important to get the assent as well. Advanced directives. Instructions given by a patient in anticipation of the need for a medical decision. Details vary per state law. Oral advance directives, that's incapacitated patients' prior oral statements, commonly used as guide. So if they tell you just orally that I do not want to be resuscitated if I go down, right? So you gotta respect that. But that doesn't mean you don't do, any other treatment like giving them oxygen, intubation and all that. You still do that. All you don't do is, if he flatlines, you don't defib them. That's what it means. Incapacitated, unless they tell you I don't want any invasive procedures either, then you just give them oxygen, and that's all you can do. So incapacitated patients' prior oral statements, commonly used as guides, so DNRs. Problems arise. Sorry, not DNRs. That would be a written one. So just orally communicated something. Problems arise from variance in interpretation. So that's a major thing. If he says, "Yeah, I agreed with you before," and then he just goes into coma or something, so then that could be interpreted as, okay, so was he agreeing with this or this, kind of like that. If patient was informed, directive was specific, patient made a choice, and decision was repeated over time to multiple people, then the oral directive is more valid as well. So the more people who heard him say it can, back it up. So then it's much easier to, if you're in court, then it's much easier to prove yourself. Written advance directive delineates specific healthcare interventions that patients anticipates accepting or rejecting during treatment for a critical or life-threatening illness. A living will is an example. That's DNR, never mind. So this is just, their wishes have been written on a paper by a lawyer. So okay, this is the lawyer one. So it's just written a living will, I guess. So delineates specific healthcare interventions that patient anticipates accepting or rejecting during treatment. So yeah, basically they tell you that I don't mind getting invasive treatment, but don't give me a resuscitation kind of thing, I guess. So, or don't defib me or something like that. So that would be in the will. Medical power of attorney. So patient designates an agent to make medical decisions in the event that the patient loses decision-making capacity. Patient may also specify decision in clinical situations. specifically, right? It can be revoked by a patient if decision-making capacity is intact. More flexible than a living will. So, okay. Then you have do not resuscitate order. So this was the one with the lawyer. This is just power of attorney. So that could be given to anyone. It could be a relative, it could be a third party, or legal surrogate, anyone. Do not resuscitate order, DNR. Order prohibits cardiopulmonary resuscitation, CPR. Patients may still consider other life-sustaining measures like intubation, feeding tube, or chemotherapy. Just if they flatline, they don't want to be brought back. Okay. Ventilator-assisted life support. Ideally, discussions with patients occur before ventilator support is necessary. So usually this stuff, the long forms that nurses make you fill out when you go to a hospital emergency departments, that's gonna question all of this. Like, do you have a living will? Do you have a advanced directive? Do you have like a power of attorney and all that? Or do you have what are your wishes or stuff? I don't know, but what's in the form. But usually this is all asked during that time when they come in. So ideally, discussions with patients occur before ventilator support is necessary. However, information about patient preferences may be absent at the time patients require this intervention to survive. Medical decision making frequently relies on surrogate decision makers, so patient identified or legally appointed. When discussing the continuation or withdrawal of ventilatory support, focusing on both the prognosis of the condition and the believed wishes of the patient. So like Mormons and them, they don't believe in that stuff. So if they don't have anyone, I guess, I don't know. But if the spouse tells you that this is what he would have wanted, you believe them, even though if it sounds something like harmful, or something that if something needed to be done and they don't want it to be done, then you believe the spouse still, because you gotta respect them and you gotta believe them and their religious beliefs. Like what was it? Like a girl with ectopic pregnancy tells you that I cannot, which is controversial now, but if she tells you that in my religion it's not allowed to abort or get rid of this or something like that, I don't know, but that you try to convince them to go through with it, but if they still say no, you don't do it. But obviously this is about ventilator assisted life support, not ectopic pregnancy, so let's continue. If surrogates indicate patient would not have wanted to receive life support with ventilation, which is withhold or withdraw life support regardless of what the surrogate prefers. Right, so that's what that means. If the decision is made to withhold or withdraw life support, involve palliative care, chaplain or services, and the primary care physician in the medical discussions with the family and provide emotional support. So, and the primary care physician in the medical discussions and the family and provide emotional support. Yeah. That's pretty straightforward. So just know that the spouse makes the decision, or unless they already told you what they wanted. That's all. Surrogate decision maker. So this is if a patient loses decision making capacity and has not prepared an advanced directive. Individuals or surrogates who know the patient must determine what the patient would have done. Priority of surrogates is spouse, obviously, first, then the adult children, then parents, then adult siblings, and then comes the friends or other relatives. The spouse chips in. That's one way to remember it, but I think it's pretty obvious. Uh, these ones are going to be the closest to the patient, and then comes the parents, because I don't know, parental issues. But spouse always gets the right because they know them the most. But what happens when they don't have a spouse and they have children, and they have a older son and a younger sister? Uh, who makes the decision? Say the son wants, option A, and then daughter wants option B to be done. What do you do? Do you listen to the son because he's the son? Do you believe in patriarchy? Or, you know, do you listen to the daughter because she was the one taking care of the person, and the person lived with the daughter for 5 years? Ethically, it sounds like you should listen to the daughter, doesn't it? But you would, legally, you can't do that. So you gotta plan a discussion between the daughter and the son, and try to come to a one answer, like one decision, and not a split decision. That's usually what you're going to try to do. You don't involve the ethics board. You don't involve the judge or anything. This is you try to have them discuss and come to an agreement with one of the options. Confidentiality. Confidentiality respects patient privacy and autonomy. If the patient is incapacitated or the situation is emergent, disclosing information to family and friends should be guided by professional judgment of patient's best interest. The patient may voluntarily waive the right to confidentiality. For example, insurance company request. General principles for exception to confidentiality is potential physical harm to self or others in serious and imminent. So this usually applies to psychologists. So if they have a person who tells them that today they want to go home and just kill this person, then you can you don't have to worry about doctor-patient confidentiality. You are supposed to call the person who is who's going to be harmed, and then you can just tell them this is what is this person told you, and then you also call the cops and tell them that this is what this person told me, kind of thing. So if potential harm to self, like they say I want to commit suicide, or they want to kill their spouse or something, is serious and imminent. Another is alternative means to warn or protect those at risk is not possible. Alternative means to warn or protect those at risk is not possible. So that's when you tell the cops, I guess, right? And then their steps can be taken to prevent them. So you can call them up, kind of thing. Okay. So here are examples of exceptions in patient confidentiality. Many are state specific. So wherever you're working, you gotta check it out. Include the following. So the physician's good judgment saved the day. So patients with suicidal or homicidal ideation, abuse. So you see a child who, the question was that mother and father come in with a baby, and baby has bruises all over the body, and they tell you that the baby rolled off the bed and he fell, and then that's how the bruises came about. So they're lying, because you listen to me, and when I told you that babies don't roll until they're 4 months old, not 2 months old. So then you figured out that they were lying. So that's when you can call them up, or they see an adult who's elderly, and they're scared to go home, or uh, they have frequent falls or something, or just their general appearance seems like they're not taking care of themselves and they're being neglected in their house. That also accounts for that abuse, elder abuse, and or prisoners. Okay, so prisoners don't get the right to confidentiality. Duty to protect. State-specific laws that sometimes allow a physician to inform or somehow protect potential victims from harm. Sorry, right? So that's when you can call. If you can call the cops, you would. Patients with epilepsy and other impaired automobile drivers. Normally, you don't directly contact them. You contact your supervisor, and they'll let you know what you need to do. Okay. Patients with epilepsy and other impaired automobile drivers. Patients with epilepsy and other automobile. Right, so you have to let the DMV know about this. Reportable diseases, for example, STIs, hepatitis, food poisoning. Physicians may have a duty to warn public officials, who will then notify people at risk. Dangerous communicable diseases, such as TB or Ebola, may require involuntary treatment. Right. This is the main one right here. So they'll tell you that this person came in and he was found to have gonorrhea or something. So what do? Do you tell them, the spouse, even though he tells you that you can't tell my spouse, she can't find out I cheated on her. So what do? Do you tell them, or what? You actually try to convince the patient to tell the person, but if they're still adamant about it, you gotta tell them. You gotta push that. If you don't, then I have to, which will be worse, kind of thing. It would be better if it came from you. So that's the kind of answers you would pick. Those are the kinds of answers. You try to not go against anybody's will. You don't force anything on anyone. But over here, if they have a venereal disease or STI, you gotta push. So over here, that is an exception. Accepting gifts from patients, a complex subject without definitive regulations. Some argue that the patient-physician relationship is strengthened through accepting a gift from a patient, while others argue that negative consequences outweigh the benefits of accepting a gift. So a patient was really happy and he came in with a box of cookie, a card, flowers, and season tickets to see the Yankees or something, right? So what do? Do you just tell them, oh, I can't accept this? I can't accept this. I'm just glad that I was able to help, or something like that. Or is there something else you can do? So let's read about it and then we'll answer that. In practice, patients often present items such as cards, baked goods, and inexpensive gifts to physicians. The physician's decision to accept or decline is based on an individual assessment of whether or not the risk of harm outweighs the potential benefit. Okay. Physicians should not accept gifts that are inappropriately large or valuable. Gifts should not be accepted if the physician identifies that the gift could detrimentally affect patient care. Gifts that may cause emotional or financial stress for the patient should not be accepted. If a gift violates any of the guidelines above, the patient best practice is to thank the patient for offering a kind gift, but politely indicate that it must be declined. Right? During this conversation, it should be emphasized that the incident does not influence the physician-patient relationship in any way. Okay, that's the main thing. So back to that question, what would you do? The patient comes in with baked goods, cards, flowers, and season tickets to Yankees. You would tell them that I'm really glad. You would take the card, you would take the flower, maybe even the cookies if they're like store bought, or something like that, or they made it. But you can't accept the Yankee tickets, right? Because that's a large sum, and that's inappropriately large or valuable thing. So you would give those back, and just tell them I'm happy to accept this and your appreciation for all of this. Because then you're not trying to upset the patient either, right? They really want to show their appreciation, so you gotta show them that you appreciate that as well. But ideally, nobody's gonna look at this. Obviously, these are ethics, but ideally, what you would do is just tell them you just take the card and not accept anything, because if someone actually sees you doing this, they would feel like they need to do this as well, and ethically that's not right. Public health sciences, communication skills, patient-centered interviewing techniques. Okay, so introduction. So when they come, what do you do? So introduction, introduce yourself and ask the patient their name and how they would like to be addressed. All right. Address the patient by the name and pronouns given. Sit at eye level near the patient. Okay. So basically this is about, it's a older male, and then how do you talk to them? Do you tell them, talk to them, hello Mr. this or Mr. whatever last name, John Smith or John or Smith or Mr. Smith, Mr. John. We shouldn't assume anything, because that can hurt the reputation, right? So you should just straight up ask them, and most likely they'll just tell you. Agenda setting. So identify concerns and set goals by developing joint agenda between physician and the patient. So you discuss their, lab work, and then tell them what's concerning about it, and then what you need to do to get that to the target. And then you come up with a plan with the patient as well. So is it okay if we just, give you some fluids and stuff like that? And they're like, yeah, okay. Reflection. Actively listen and synthesize information offered by the patient, particularly with respect to primary concerns. That just means, say, you came in from your round and you're talking to this patient, and this patient is really upset because they're like, it's been already 2 hours after lunch and I still haven't gotten my lunch. What the hell, man? This is how you run your hospital? So what do you say? It's like, yo, we've been busy? Or do you be like, yeah, you're right, actually, let me go check up on it and then we'll continue? So then that would be the answer. You respect their concerns and you take care of it right away. And then after that, you go on and talk about other things. Validation. Legitimize or affirm the patient's perspective. Right, if they're telling you, you just like, yeah, you're right. Yep. Yeah, that could be true. Stuff like that. So, recapitulation. Summarize what the patient has said so far to ensure correct interpretation. Right? So this is just making sure that they comprehend everything, kind of thing, right? So summarize what the patient has said so far to ensure correct interpretation. Facilitation. Encourage the patient to speak freely without guiding responses or leading questions. Right? What leading questions mean is you're asking yes or no, right? That's what leading questions are. A question that prompts or encourages the desired answer. That's what it is. Okay. So don't do that. You don't want to manipulate or coerce a decision, right? Because then they can come back and sue you because of that. So just encourage them to speak freely. Uh, Give them some time to think it through. Uh, don't be awkward, because when you're awkward, you start speaking. Let them have their time. Okay. Allow the patient to ask questions throughout the encounter. Okay. You just tell them you can just talk to me whenever you want. You can ask me any questions. And all of these things, if done right, it will improve the rapport, repartee between patient and doctor, right? And it will strengthen relationship as well. Establishing rapport. Pros. So partnership. Work together with patient to identify primary concerns and develop preferred solutions. Empathy. Acknowledge the emotions displayed and demonstrate understanding of why the patient is feeling that way. Okay, so this is gonna come and you gotta remember this whole thing, because that's what the question stem's gonna have. And then you have to figure out at what step are you, and then those are the kind of answers you're going to pick. So again, partnership. Work together with the patient to identify primary concerns and develop preferred solutions. Empathy. Acknowledge the emotions displayed and demonstrate understanding of why the patient is feeling that way. So say a patient comes in and they're like, Doc, I've been feeling pretty down lately, and then you ask them why, and it's because they have been feeling very heavy, right? So that then you like, do you just tell them, oh, you don't look heavy at all? No, that's not showing empathy. It's like, okay, I understand where you're coming from. That sounds like an empathetic answer, right? Or if you don't understand, then you can just be like, oh, I see, or something like that. But you don't, affirm their concern or something like that. So those are not the kind of answers you would pick in ethics. Apology. Take personal responsibility when appropriate. So it's like a person in emergency, they waited for 2 hours to get a treatment, and then they come into your office or your clinic or whatever, and then they tell you, I've been waiting outside for 2 hours to just get treatment, and people coming in, just taking, and so what do? You actually, apologize for the wait, and that's it. You don't give excuses, the system was down or something. You don't tell them that. You just tell them sorry, that's it, and then be like, so what can I help you with today? And then you move on. You don't give excuses at all. Respect. Commend the patient for coming in to discuss a problem, pushing through challenging circumstances, keeping a positive attitude, or other constructive behaviors. Okay, so this is important, obviously. Commend the patient for coming in, to discuss a problem, pushing through challenging circumstances. So the patient comes in like, Doc, I felt good today. Okay, 2 minutes. So Doc, I felt good today. I actually went on a hike this weekend. I walked. I ate a little better. I made better choices, and I feel a little healthier. Then yes, even if their blood work says different, you tell them that's pretty good, right? You push them up. You don't, confront them for whatever that word says or something. You just tell them, yeah, good job, keep it going, you're doing good, and push through. The main thing is that you started, you say positive things like that. So you keep a positive attitude or other constructive behaviors. Then legitimization. Assure patient that emotional responses are understandable or common, and support. Reassure patient that you will work together through difficult times and offer appropriate resources. Right, so all of this are pearls for establishing rapport. Spikes. This is also important. This is majority of ethics question is you're going to be using this model here. So delivering bad news. How do you deliver bad news? So it's going to be this and this. These two are going to be your ethics question helpers, pros and spikes. So spikes, setting. You offer in advance the patient to bring support, right? So let me give you a scenario. So in the scenario, it could be that the patient is in the ward and then they have family there, right? Do you start talking to them right away? No. You gotta give them a time. Tell them that you're gonna talk at 2. Where you gonna talk? It's gonna be somewhere private. And yeah, so that's setting. Okay, so offer in advance for the patient to bring support. The family's there. Eliminate distractions. Ensure privacy. So it's gonna be in a room where it's private, and sit down with the patient to talk. If they want the family there, they can have it. If they don't, then you do it just with the patient. Perception. Determine the patient's understanding and acceptance of the situation. You ask them, so do you know why you were here in the hospital in the first place? What happened to you? Do you know what's going on? Like, stuff like that. You ask them first. So you determine if they understand and accept the situation. Then invitation. Obtain the patient's permission to disclose the news and what level of detail is desired. So then you tell them, okay, so I have your lab report. Do you want to know about it? Kind of like that. Knowledge. Share the information in small pieces without medical jargon. You don't give them, big words like you got basal, BPH, so basal prostatic hyperplasia or something. They're not gonna know what that is, right? So you avoid big words like that. Not really big, but just an example. Okay, allowing time to process. Assess the patient's understanding as well. So you confirm that they know what they have. Sometimes they ask you to write it down. You do that too. So you write down what they have, like in words, so they can tell their relatives when they go home that this is what the doctor told me I have, kind of thing. So if they want it in writing, you can do that. Then emotions. Acknowledge the patient's emotions and provide opportunity to express them. Listen and offer empathetic responses. So first the setting you gotta look for. Then you ask if then you basically see if they know what they're what's the word? I'm missing on the word. Anyways, so setting and then perception, and then you ask them if they want to know what the results are, and then you see if they understand the result and what does the result mean. And then if they're crying, if they're feeling off or something, you respect that. You provide them tissues and all that stuff. And when they want to talk, like, why is it happening to me? I've always been straight in my whole life, and so, empathetic responses to that. And strategy. So if the patient feels ready, discuss the treatment. You don't just jump into strategy after you tell them the result and all that, right? So you gotta go in these steps. Now, when they give you the question stem, it could be that they're already through the first 3 steps and you're here, right? So then the response would be something about this. So do you understand what's happening to you? Do you understand what condition you have, or something like that? Or they can jump into emotions like you already told them they have cancer and then they're crying. So what do? You don't do anything. You just listen to them talking and then offer empathetic response. So it's going to be something like that, right? Or it's just that, yeah, I guess. That's it for spikes. So remember the spikes: S for settings, P for perception, I for invitation, K for knowledge, E for emotion, and S for strategy. How much time do we have? 4 minutes. Let's get through this one. Gender and sexuality inclusive history taking. Avoid making assumption about sexual orientation, gender identity, gender expression, and behavior. For example, a patient who identifies as heterosexual may engage in same-sex sexual activity. Use gender-neutral terms to refer to the patient's partner rather than assuming a spouse's gender, like your husband. Patient's sex assigned at birth and gender identity may differ. Consider stating what pronouns you use when you introduce yourself. So, for example, I'm Dr. Smith, and I use she, her pronoun, and asking patients how they would like to be addressed. Normally, a nurse would give you a heads up if something like this is going down, and you gotta be considerate about this. So, but on steps, this is how you approach it. Reassure them about the confidentiality of their appointments and be sensitive to the fact that patients may not be open about their sexual orientation or gender identity to others in their life. Do not bring up gender or sexuality if it is not relevant to the visit. For example, a gender non-conforming partner seeking care for a hand laceration. Right? You don't need to know what gender they are for that. Okay. So for this, usually it's gonna be someone. They're gonna like show. They're gonna paint a picture that the person has dyed hair and like half the hair is gone or something like that. It's gonna be a male or female, I don't know. And then they're gonna ask you, how are you gonna introduce yourself, right? And then you tell them that this and this is your pronoun, and then again here, right? Introduction. So you ask them how they would like to be referred to as. Okay, we'll come back in 5 minutes and continue from here. Inclusive history taking. Identify the problem through the patient's perspective. Ask the patient to describe the problem in their own words, or how the patient would describe the problem in their family, to their family and friends. Identify cultural perceptions of factors leading to a problem. Ask the patient to explain why they think they are experiencing their problem. Identify how the patient's background influences their problem. Ask the patient about what makes their problem better or worse. Investigate roles of family, community, and spirituality. Identify how culture may impact current and future interventions. Ask the patient if they have any concerns about the current plan of treatment and if they have any suggestions. If they do not want to follow medical advice, investigate if there is a way to combine their plans with the standard medical regimen or regime. Identify possible barriers to care based on culture. Ask the patient if there is anything that would prevent them from seeking care in a standard medical institution. Probe for explanations and what may increase the chance of maintaining a good patient-physician relationship. Yeah, so you gotta be sensitive about all of that. The culture, religion, when they're describing their problems. That's all. Motivational interviewing, counseling technique to facilitate behavior modification by helping patients resolve ambivalence and about change. Useful for many conditions, for example, nicotine dependence, obesity. Helpful when patient has some desire to change, but it does not require that the patient be committed to making the change. Okay. May invoke may involve asking patients to examine how their behavior interferes with their life or why they might want to change it. Assess barriers, for example, food excess, untreated trauma, that may make behavior change difficult. Assessing a patient's readiness for change is also important for guiding physician suggested goals. These goals should be specific, measurable, achievable, relevant, and time bound. Okay, so motivational interviewing is important because you'll have patients who wants to lose weight, and this is how you're gonna approach it. Okay, so you gotta figure out at which step the question is. It could be that you have already made the plan and then it's just about achieving it, right? So you're at this step, achievable step, right? Or you already made the change, and then I think there's another. We'll come across something about that after, but yeah. The point of this thing is that if they tell you that they are trying to make a change, that it it could be as small as not eating or not drinking Coke, you know, that's still something compared to when they were drinking a Coke every day, right? So they're still doing that, so that's a huge thing. So you should appreciate that and tell them that's a huge thing. Be motivational, basically, and that way you can ask about other stuff as well, like, okay, so how much food do you always get when you go to the groceries, or did something in the past made you want to do this? It could be stress eating or something like that in terms of losing weight. Okay. Trauma informed care. Patient with history of psychological trauma should receive thorough behavioral health screenings, regularly assess mood, substance use, social support, and suicide risk. Focus assessments on trauma-related symptoms that interfere with social and occupational function. Do not probe into details of the incident. Always be empathetic. Do not ask invasive questions requiring the patient to describe the trauma in detail. Ask permission prior to discussion. Right? So a person who has been raped or, something like that. So you gotta be sensitive about those kind of things. Ask permission prior to the discussion. So you gotta tell them that, okay, so I need to ask you a few questions if that's okay with you. Like that as well. If it's someone with suicide risk, you gotta be careful with that as well. Before the physical exam, reassure patients that they may signal to end it immediately if they experience too much physical or emotional discomfort. Offer the presence of additional staff to support. There's always a good reminder, in case of that. Even for suicide, have someone else there as well. The 4 R's of trauma-informed care is realize, recognize, respond, resist, re-traumatization. Okay, resist that. Respond empathetically, respectfully. Recognize what the problem is, or what they're suffering from. Realize that there is something happening here, first and foremost, right? Okay, communicating with patients with disabilities. Patients may identify with person first, that is, a person with a disability, or identity first, that is, a disabled person. Language. I guess these are new terms because I was not aware of these. Okay. Ask patient what terms they use. Under most circumstances, talk directly to the patient. Do not assume the non-verbal patients do not understand. Right? Don't be rude. You talk to them and try to see if they understand you. Accompanying Caregivers can add information to any discussion as needed. Ask if assistance is desired rather than assuming the patient cannot do something alone. Most people, including people with disabilities, value their independence. For patients with speech difficulties, provide extra time for the interview. If their speech is difficult to understand, consider asking them to write down a few words or ask them to rephrase their sentence. Repeat what they said to ensure you understood it correctly. For patients with a cognitive impairment, use concrete, specific language. Ask simple, direct questions. Eliminate background noise and distractions. Do not assume the patient can read. Okay, so adjust to how the patient understands best. For example, use hand gestures or ask them to demonstrate a task. Ask patients who are deaf or hard of hearing their preferred mode of communication. Use light touch or waving to get their attention. For patients who prefer to speak and lip read, eliminate background noise, face the patient, and do not change your mode of speaking. Consider using an interpreter when necessary. As with other parts of medical history, do not bring up a disability if it is not relevant to a visit. For example, patient in a wheelchair with an ear inspection. Do not skip relevant parts of the physical exam, even if the disability makes the exam challenging. Right? There's a question about a couple comes and this person needs a surgery in the ear. It's an invasive one, and you're explaining, you're trying to get the informed consent or something, right? So you're explaining to them what the procedure has. So the patient is looking at you and he's nodding and stuff, and you're supposed to realize that this person has a history of recurrent infections in the ear. So chances are this person cannot hear you right now. That's why he's just blankly staring at you, and when you're asking questions, he's not responding. It's gonna be someone of ethnically different. It's like it could be Hispanic or someone like that. So they would try to see if you assume that they don't understand English or something. It's not that they don't understand English. It's just that the dude can't hear you, right? And so how do you communicate to them? Do you talk to the girlfriend? That's not going to be the answer. Do you talk loudly, staring at them with air, closing the door and avoiding no background noises? That's not the answer. The answer is, at first you're gonna ask them to repeat what you said. So when they can't, you're gonna write it down, and then you ask them if they still can't talk back. Then you try to draw, or you use diagrams and stuff to show it to them. The answer was something like that. You don't involve a third party if you don't need to. Again. So, okay. Do not skip relevant part of examination, even if the display makes the exam challenging. Use of interpreters. This question will be like, Hispanic family comes in or something like that. I don't know why I'm picking on Hispanics, but that's what the UWorld questions usually have. It's going to be someone non-English speaking family comes in with a daughter who does. Or it's going to be a daughter and a mother, elderly mother, and they're going to be, and the mother has the elder grandmother or whatever mother has the problem, and she can't speak English, and then you need to communicate to them, and ask questions, right? So what do you do? Do you ask the daughter to communicate the questions to the mother, or do you call up a colleague or a nurse who's fluent in Spanish, right? Or you knew Spanish because you did a course in college, so you know a few words. So do you do it yourself, or do you ask for an interpreter, but they're not able to come in for like next 2 hours to help you out? So how do you proceed? So the first thing you do is you telephone in the interpreter. So there are interpreters who can be on phones and still do it. So you do that. If someone can't physically come and interpret it, you don't ask the nurse. You don't do it yourself. You don't ask the daughter to do it, right? Because there are going to be some words that you don't understand, or the daughter doesn't understand, or or the nurse doesn't understand how to communicate it, right? But the medical interpreters are, you know, skilled in this, so this is what they do. So they know how to communicate these things. So you use an interpreter, okay? So visit with a patient who speaks little English should utilize a professionally trained medical interpreter, unless the physician is conversationally fluent in the patient's preferred language. If an interpreter is unavailable in person, interpretation services may be provided by telephone or video call. Okay, so that's important. So so if an interpreter is unavailable in person, interpretation services may be provided by telephone or video call. If the patient prefers to utilize a family member, they should be recorded in the chart. Okay. Do not assume that the patient is a poor English speaker because of name, skin tone, or accent. Ask the patient what language is preferred. The physician should make eye contact with the patient and speak to them directly, without use of third-person statements such as "tell him." Allow extra time for the interview and ask one question at a time. For in-person spoken language interpretation, the interpreter should ideally be next to or slightly behind the patient. For sign language interpretation, the interpreter should be next to or slightly behind the physician. In case of emergency, facilitate communication by any tools available, for example, friends, family, sketches, and interpreter apps. Okay, so this is a new thing. In case of emergency, facilitate communication by any tools. Okay, so like diagram and stuff like that, right? Friends, family, sketches, interpreter apps, even though they do not comprise standard procedure otherwise, right? So this goes back to me talking about the situation here with the person having ear infection, so he can't read. So don't assume he doesn't know how to can't hear you, so don't assume that he doesn't know English. You can try using diagrams and stuff, even though that's not the standard, rather than assuming he can't understand you. That's the main thing. Challenging patient and ethical scenarios. The most appropriate response is usually one that acknowledges the issue, validates emotion, and is open-ended. This is usually the one that will help you cross out like 3 out of 5 answers. That is an open-ended question, because 3 out of 5 times it's not going to be open-ended. So you can just cross those out. Empathetic and patient-centered, and this is the other one that's going to help you answer it, is the question patient-centered. It often honors one or more of the principles of autonomy, beneficence, non-malfeasance, and justice. Appropriate responses are respectful of patients and other members of the healthcare team. Situation and appropriate responses. So patient is not adherent, so appropriate response would be determine whether there are financial, logistical, or other obstacle preventing the patient's adherence. Do not coerce the patient into adhering or refer the patient to another physician. Schedule regular follow-up visits to track patient progress. Patient desires and unnecessary procedure. So attempt to understand why the patient wants the procedure and address underlying concerns. Do not refuse to see the patient or refer to another physician. Again, avoid a third party involvement. Right? Avoid performing unnecessary procedures as well, right? Unless you have your own clinic and you're a, plastic surgeon. Patient has difficulty taking medications. Determine what factors are involved in the patient's difficulties. Okay. If comprehension or memory are issues, use techniques such as providing written instructions, using the teach-back method, or simplifying treatment regimen. Right. So teach-back method is you tell them how to do it, and then you ask them how will you be taking it, and then you confirm it. Okay. Family members ask for information about patient's prognosis. Avoid discussing issues with relatives without the patient's permission, obviously. So the other days on the group, someone was asking, right? So you have two sisters, one sister in the ward, and the other sister is telling you, "Come, I need to talk to you about something relating to this." What do? Do you avoid talking to the sister and focus on the patient, or it wasn't? It's not an emergency, right? It was not an emergency. So what do? You actually go talk to the sister and you listen, but you don't talk to them about the treatment or anything about your patient, right? So the sister is going to tell you what her concerns are and all that. You just take it in and see if that, if there's any useful information in that. Another thing is just, always say yes to gossip. That works for me. Family member asks for information about patient's prognosis. So say yes to gossip, but don't gossip. Right? Family members ask for information about patient's prognosis. Avoid discussing issues with relatives without the patient's permission. This sometimes becomes hard to do in real life, but you can tell them. It's not like you can't completely tell them anything about it. You can tell them if the patient is stable or not, right? So that is you don't need a permission for that, because you have a whole family worried outside of the operating room. You can go there and tell them, okay, the patient is stable now, but that's as far as it goes. There's not that much you can communicate without permission. A patient's family member asks you not to disclose the results of a test if the prognosis is poor, because the patient will be unable to handle it. Right? So explore why the family member believes this would be detrimental, including possible cultural factors. Explain that if the patient would like to know information concerning care, it will not be withheld. Okay. So if the patient tells you that, yeah, I want to know, then you can't withhold the information. However, if you believe the patient might seriously harm himself or others if informed, like, they have a terminal illness and they don't know how to handle it, they might just off themselves, then it's something like that. You may invoke the therapeutic privilege time. That's what it was. That's where I brought up this scenario, right? And withhold the information. A 17-year-old is pregnant and requests an abortion. Many states require again, this is a very controversial in US, right? Controversial topic. So many states require parental notification or consent for minors for an abortion. Unless there are specific medical risks associated with pregnancy, a physician should not sway the patient's decision for or against an elective abortion. regardless of patient's age or fetal condition. Discuss options for terminating the pregnancy and refer to abortion care if needed. Yeah. So it was on the news that nowadays, like after the whole, you know, uh, the Supreme Court overturned the case, they, uh, doctors and hospitals were calling up their lawyers to check if they would get in trouble for treating ectopic pregnancy, which is kind of sad, right? Because there's a person in pain and you gotta worry about your legal issues. Okay, so yeah, you have a person who comes in and then they tell you they want to have abortion. What do you do? Tell them about God? Do you tell them about why they shouldn't do it or anything? No, you ask them why they want to do it. You assess the situation and then you tell them what their options are. Okay. A 15-year-old is pregnant and wants to raise the child. The patient's parents want you to tell the patient to give the child up for adoption. Okay, so 15-year-old is pregnant and wants to raise the child, but the 15-year-old's parents want you to tell the patient to give the child up for adoption. What do? The patient retains the right? Because remember, if she was a mother, a teen parent, then she has the right. She's emancipated, right? Okay, where to go? Yeah, so she's emancipated, right? So you don't really need to listen to the parents. So the patient retains the right to make decisions regarding the child even if the patient's parents disagree. Provide information to the teenager about the practical aspects of caring for a baby. Discuss options for terminating the pregnancy if requested. Okay, that's important. You don't just voluntarily throw that out there. Then encourage discussion between the patient and parents to reach the best decision. Similar to that thing I talked about with the siblings, right? You encourage the discussion there as well. And this is usually if there's a conflict between family members, this is what the answer will be. Encourage discussion with that. A terminally ill patient requests physician-assisted dying. The overwhelming majority of states prohibit most forms of physician-assisted dying. Physicians may, however, prescribe medically appropriate analgesics even if they potentially shorten the patient's life. And that's how they usually do these things. By they, I don't know who, but right. Allegedly, the patient are like, screaming in pain and they're terminal. So you can give them morphine, and you know what morphine does, right? It depresses respiration, so that can shorten their life. But that is legal. What is not legal is you doing procedures to end their life. Patient is, or even just telling them how to do it, like what drugs to take and stuff like that. Patient is suicidal, so assess the seriousness of the threat. If patient is, by the way, this is step 1, okay? Like you can give them morphine, even if you know there are suicidal ideations there, and they tell you that they need more morphine, you can give it to them according to step. It's not according to me. None of this is according to me. I'll tell you when it's according to me. Okay, patient is suicidal. Assess the seriousness of the threat. If patient is actively suicidal with a plan, suggest remaining in the hospital voluntarily. Patient may be hospitalized involuntarily if needed. Okay. Patient states that you are attractive and asks you if you would go on a date. So you use a chaperone if necessary. Romantic relationships with patients are never appropriate. Set firm professional boundaries with direct communication. Uh, Transition care to another physician if necessary. This is the only time where a third party burden is okay. And these kind of cases are going to be usually with psychiatrists, uh, like in the question stems. Okay. A woman who had a mastectomy says she now feels ugly. Find out why the patient feels that way, this way. Do not offer falsely reassuring statements like, "Oh, you still look good," right? Don't do that. You just offer empathy and all that stuff, right? So pick an answer like that. Don't pick an answer that says, "Oh, you still look good." Patient is angry about the long time spent in the waiting room. So acknowledging the patient's anger, but do not take a patient's anger personally. Thank the patient for being patient and apologize for any inconvenience. Stay away from efforts to explain the delay. Right? Don't give excuses. Thank the patient and then apologize for the inconvenience and then just move on. Sometimes in the question they will explain that you already apologized. So what's your next step? Like, what will you say? So then you just say, "What can I help you with?" What made you come here, or how are you feeling, or something like that. You don't say, if they explain that you already apologized, you'd say, "Yeah, so I'm sorry about that, but what can I help you with?" You don't pick an answer like that then, because you already apologized. You're not going to say, "I'm sorry" again. Okay. Patient is upset with treatment received from another physician. Suggest that the patient speak directly to the physician regarding the concern. If the problem is with a member of the office staff, reassure the patient you will speak to that person. Okay. Challenging patient with an ethical scenarios. Okay. Continuing. An invasive test is performed on the wrong patient. So regardless of the outcome, a physician is ethically obligated to inform a patient that a mistake has been made. Okay, so like a dental surgeon mixing up two rooms, so he goes in and just rips out a molar, and when he was from room A, when he was supposed to do it, and the patient in the room B, that was under. Something like that. So how would you prevent this, right? Something like that. So the way you prevent is you have two separate doctors that are going to be operating, confirm the type of surgery that's happening separately, so not together but separately. And then you have, or if you don't have two doctors, it can be the head nurse doing it and the doctor operating. It can be like that as well, but it has to be separate. You can't, be standing around with the doctor next to you and you both looking at it together. Okay. Patient requires a treatment not covered by insurance. Discuss all treatment options with patients, even if some are not covered by their insurance companies. Okay, so even if it's not covered by insurance, you still give them all the treatment options. Inform patient of financial assistance programs. So obviously this goes without saying, but none of your decisions should be based on their financial conditions, right? A 7-year-old boy loses a sister to cancer and now feels responsible. At ages 5 to 7, children begin to understand that death is permanent. All life function and completely at death, and everything that is alive eventually dies. Wow, that just got heavy. Provide a direct, concrete description of his sister's death. Avoid cliches and euphemism. Reassure the boy that he's not responsible identify and normalize fear and feelings, and encourage play and healthy coping behaviors. For example, remembering her in his own way. Right? Yeah. Patient is victim of intimate partner violence. Ask if patient is safe and help devise an emergency plan if there isn't one. Ask patient direct, open-ended questions about exam findings and summarize patient's answer back to them. Ask if patient has any questions. Do not necessarily pressure patient to leave a partner or disclose the incident to the authorities unless required by the state law, right? So it could be a patient who comes in with like black eye and bruises on her arm, but she tells you that she slipped off the stairs. So what do? First, you ask them, right? If they're, you know, ask patient directly, firstly, and if they tell you no, I just slipped off the stairs, then you don't push it, right? If clearly they don't want to talk about it, and it's not your duty to force them to talk about it. But what you can do is give them all the information you have, like the pamphlets for domestic abuse and violence and all that. That's the most you can do at that point. If they, unless they give you more information, then you can, you know, go back and forth and ask them, do they have anywhere else in the city where they can live, or with their family or someone, and stuff like that. But if they don't want to do it, talk about it, you just hand them the pamphlet. Patients wants to try alternative or holistic medicine. Explore any underlying reasons with the patient in a supportive, non-judgmental manner. Advise the patient of known benefits and risks of treatment, right, including adverse effects, contraindications, and medications interactions. Consider referral to an appropriate complementary or alternative medicine provider. This will never be the answer, right? That's third party involvement. Normally, ideally, you know, they assume that you know about all the holistic medicines and all that, but you for steps. But if you don't know, they might tell you that you have never heard of this. So what do? So you tell them, okay, so I'll look up these medicines and read up on it so I can better inform you about it. So something like that. Advise the patient of known benefits and risks of treatment. So if they say that you know about the drug, so what do? And this is the answer, right? Including its contraindication and medication interactions. But even like in a real world, if something works for someone, you shouldn't be the one telling them not to do it, right? Because again, if that goes to beneficence and all that, autonomy and that stuff. Seek guidance in what was it? Okay, yeah. So physician colleague presents to work impaired. This presents a potential risk to patient safety. You have an ethical and usually a legal obligation to report impaired. Right. So ethical, but usually a legal obligation to report impaired colleagues, so they can seize patient care and receive appropriate assistance in timely manner. Seek guidance in reporting as procedures and applicable law vary by institution and state. So there's like a question about you interning at a hospital and they had like a party you were invited to. So you went to the party and then you saw your superior, or you saw a doctor, not superior. So you saw a doctor who was having a drink, but then in the middle of the drinks he was getting calls from the clinic. So he would go downstairs and perform his duties and then come back and continue drinking again. So what do? Do you talk to the person? Do you call up the medical board? You call up the ECFMG. No, what you do is call up. You talk to your supervisor, right? And then they will take care of it. You don't talk to anyone else other than your supervisor. Usually, that's the answer. Or the head of the department or something like that. Someone in authority. That's who you talk to. But you don't go outside of the hospital. That's not your job. Okay. There's also this one question that like a person on cocaine comes in with signs and symptoms of cocaine, so you're supposed to understand that it's cocaine overdose, and then the doctor prescribes beta blockers, right? So again, beta 2 action is vasodilation, cocaine is an alpha constrictor, right? So and the only thing preventing from collapsing of the veins is beta action. So if beta action is blocked, then there's unopposed action of alpha, causing severe vasoconstriction, right? So that's why a doctor who prescribes beta blockers, and then you notice that you remember from your medical school that you shouldn't give beta blockers with cocaine, right? So then what do? Do you tell the patient not to take it? Do you talk to the head of the department and tell them, or what? You talk to the doctor who prescribed, and then you tell them your concerns, and then you come up with a plan, and hopefully you get a letter of recommendation out of it. And not, how dare you teach me. Okay. So physician colleague presents to work impaired. We did that. Patient's family insists on maintaining life support after brain death has occurred, citing patient's movement when touched. Okay, so insists on maintaining life support after brain death. So brain death has occurred, but when they touch, the reflexes are still intact, right? So gently explain to the family that there is no chance of recovery and that brain death is equivalent to death. Movement is due to spinal arc reflex and is not voluntary. Bring case to appropriate ethics board regarding futility of care and withdrawal of life support. Again, this will never be the answer because you're not going to bring in a third party. You try to resolve it right there with the family. It's going to be either you do a discussion, you try to convince them, or you try to teach them, or you just, unless the question is pushing you to make a decision, these are going to be the way to go. But at the end, if they're pushing you to make a decision and the family is not convinced about it and you need the bed for different patients, then you got to take the legal route then. A pharmaceutical company offers you a sponsorship in exchange for advertising in new drugs, so reject this offer. Generally decline gifts and sponsorship to avoid any conflict of interest. The AMA Code of Ethics does make exceptions for gifts directly benefiting the patients. Special funding for medical education and students, residents, fellows, grants whose recipients are chosen by independent institutional criteria, and funds that are distributed without attribution to sponsors. Okay. Patients request a non-emergent procedure that is against your personal or religious belief. So here, if you don't believe that a person should have the right to abort or something, you shouldn't be a doctor, in my opinion. It shouldn't be up to you. You should perform your duties, what you're known for, but you do have a personal religious belief, and then you do have a right. You don't have to operate on them. You can, but you are obligated to provide further assistance. You can refer them to another doctor who can do the procedure for them. Okay, so provide accurate, unbiased information so patients can make an informed decision. in a neutral, non-judgmental manner, explain to the patient that you do not perform the procedure but offer to refer to another physician. Okay. Mother and 15-year-old daughter are unresponsive and bleeding heavily, but father refuses transfusion because they are Jehovah's Witnesses. Okay. Uh, Here, it's a emergency situation, I guess. So you don't need a. Oh wait, mother and 15-year-old daughter are unresponsive. Okay, so mother and daughter, they both are unresponsive, bleeding heavily, but father refuses transfusion because they are Jehovah's Witnesses. Okay, so here, since it's a father, that means the mother and father are husband and wife, so that's spouse. So you listen to the father for the mother because the father knows about the mother's wishes. However, for the 15-year-old, it doesn't apply because then you have implied consent for that one. Okay, so transfuse the daughter, but do not transfuse the mother. Emergent care can be refused by the healthcare proxy for an adult, particularly when patient preferences are known or reasonably inferred, but not for a minor based solely on faith. Okay? So, remember that. So, yeah, I said implied consent, but it's just, it's a minor, so and it is a life-saving procedure. So for life-saving procedure, you don't need a consent from a parent for that. Okay, but if it was a mother, you listen to the father for that, like a husband and wife. Dependent patient presents with injuries inconsistent with caretaker's story. So document detailed history and physical. If possible and appropriate, interview the patient alone. Provide any necessary medical care. If suspicion remains, contact the appropriate agencies or authorities. For example, Child and Adult Protective Services for an evaluation. Okay, so here you have to involve a third party. So this would be one of those exceptions. You can tell, yeah, so, okay. For example, Child and Adult Protective Services, and for an evaluation. Inform the caretaker of your obligations to report. Physicians are required by law to report any reasonable suspicion of abuse, neglect, or endangerment. A pediatrician recommends standard vaccinations for a patient, but the child's parent refuses. So address any concerns that parent has. Explain the risk and benefits of vaccination and why they are recommended. Do not administer routine vaccinations without the parent's consent. Again, the anti-vax movement, that's they're going to ask about that. What do? Do you, raise your tone and get angry at the mother? No, right? You cannot force you can't force treatment on anyone. No? So you convince the mother, you answer any question she has, and you be respectful. And even at the end, they choose not to do it, you don't do it. Public health sciences, healthcare delivery, disease prevention. I did a question about these in the biostat questions. The best way to remember this is P, primary, is for prevention. S is for screening, or secondary is screening. T, tertiary, is treatment. And Q, which is quaternary, is just, quit unnecessary medical interventions to minimize incidental harm. So what does that mean? It's just going to be like they're going to give you a situation, and then they're going to ask you, what type of prevention is this? And it's going to be, you're running a blood pressure checking truck or something, I don't know. And then blood pressure would come in under not prevention, because you're not doing that. It's going to be screening, right? Because you're screening for hypertension with blood pressure, so that's what that one would be. Prevention is prevent disease before it occurs, so that's your vaccinations or healthy diet and exercise to prevent diabetes, right? Then, so staying healthy is also primary, and then secondary, screen for and manage pre-symptomatic disease, so glucose screening for type 2 diabetes mellitus. Then tertiary is treat to reduce complications from disease that is ongoing, so hemoglobin, HbA1c, monitoring to guide the treatment and prevent complications. And quaternary is avoid unnecessary medical interventions to minimize incidental harm. Discontinuing sulfonylurea after multiple hypoglycemic events. Right. So that's quaternary prevention. Okay, major medical insurance plan. This is the one that confuses me, and they don't really ask you that much of it from it, but in America there are different types of plans and different providers. So exclusive provider organization is EPO, which is restricted to a limited panel except emergencies. So yeah, that. Specialist care, no referral required. Okay. So you don't need a doctor's referral to go to see these doctors in this restricted limited panels. Okay. And if it's an emergency, you can just go without worrying about which plan you have. Health maintenance organization, restricted to limited panel again. This is HMO. This is going to be the one that is the most popular one, because it's the most affordable one. So it requires referral from primary care provider. So your primary care provider needs to give you a referral to see a specialist. You can't just go straight to a nephrologist or something under HMO plans. Okay. Again, you can go to doctors in their list, and unless it's an emergency. Point of service. Patient can see providers outside the network. It doesn't have to be that. But there are higher co-pays and deductibles for out-of-network services. That means you have to co-pay and deductibles. These are. Did they explain it? That's basically how much you had to pay before the insurance kicks in. Okay, and how much percentage you have to pay compared to what the insurance pays are the deductibles. So higher copay and deductibles for out-of-network services. So they do have a network, but you can see it go outside of them as well. So this is P.H.S. So HMO, I just remember that's home. So home is where, the one that's most affordable place where you can stay. Okay. So point of service is just, piece of shit kind of thing. Because it's the highest copay and it's really not helpful. Because it requires referral from primary care as well, even though you're paying so much to see a specialist. So that's a piece of shit plan. And then you have PPO. A patient can see providers outside the network, but again, you have higher copays and deductibles for all services, but you don't need a referral. You can just go straight to a cardiologist if you need to. Okay, so that's preferred provider organization. And then you have accountable care organization. That's provider voluntarily enroll. Payments is through Medicare, and specialists voluntarily enroll. Not too sure about this one, so definitely remember HMO because that's the most affordable one and that's the most popular plans in US. uh, healthcare payment models, bundled, and there's also like with a P.O.S. or I think P.O.S. is the one, or P.P.O. They have this two different systems of saving money for this, where it doesn't get taxed. That's like health savings account and HHE account or something like that. So you put in like some amount of money, and then you don't pay taxes on them, and you can use that towards medical, uses. So that doesn't just mean like hospital or medicines. It can also mean like stuff, like your skincare serums and stuff, or pads or anything like that. You would probably find at CVS would you can use that account for that. So just for your information. Healthcare payment models, bundled payment. Healthcare organization receives a set amount per service regardless of ultimate cost to be divided among all providers and facilities involved. Okay, so that's called bundled payment. So it's a set amount per service. So now you don't have to worry about, okay, should I be getting my x-ray done? I'm going to need to pay this much, and this one is going to be this much. You don't worry about that. It's going to be a set amount, and everything's included in that. So capitation is physician receives a set amount per patient assigned to them per period of time. Okay, so here it's not that good because the physician has interest in making money. If they do, then they're gonna be quick with you, and they're gonna give you procedures that is gonna be expensive, regardless of how much the patient uses the healthcare system used by some HMOs. So they'll give you like okay, so this one is where capitation is where they'll be quick with you because they want to get you out and not use so many services, because they only get set amount of they only receive set amount. So as long as they see you, and then if it's like a stomach pain, they'll do a checkup and then be like, okay, it's just gas, you can go, without doing further investigation, kind of thing. Like, I'm not telling that this is going to be a question or something like that. It's just I'm thinking out loud. Okay. Discounted for fee for service. So insurer and or patient pays for each individual service at a discounted rate predetermined by providers and payers. This is the PPO one, for example. Fee for service, insurer and or patient pays for each individual service. Okay, and global payment, insurer and or patient pays for all expenses associated with a single incident of care with a single payment. How much time do I have? 2 minutes. Okay, so single payment, most commonly used during elective surgeries, as it covers the cost of surgery as well as the necessary pre- and post-operative visits. We have 3 pages left, so let's take a break here for Medicare and Medicaid. Right, Medicare and Medicaid, federal social health care programs that originated from amendments into the Social Security Act. So Medicare is available to patients more than 65 or more year old, less than 65 with certain disabilities, and those with end-stage renal disease. Medicaid is joint federal and state health assistance for people with limited income and or resources. Okay, so Medicare is elderly and Medicaid is for disadvantaged. Okay, so you have like a person, uh, so you have a family, a homeless family coming into the hospital, and they have like diseases, like the mother has STD, the father has like some kind of drug addiction, and the son has mental disability, right? So, uh, and they say they can't don't have finances and they can't even use financial aid or something. Who are you gonna who can get help from the government, right? That's the question. So it's the son with the disability. The son can get the help from the government themselves, so they don't have to worry about the son. uh, and that's where the question ends. Okay, so remember who can get Medicare. Okay, so it's patients more than 65 years old. If they're less than 65, then certain disabilities apply. uh, so Medicare applies to them, and those with end-stage renal kidney disease. Okay. Uh, Medicare is for elderly, and Medicaid is for the disadvantaged. Okay, so that's Medicaid is an aid for low income and or resources. The four parts of Medicare is Part A, which is hospital admissions, including hospice and skilled nursing. Okay, so A for admission, including hospice and skilled nursing. B is for basic medical bills. Okay, so B is for bills. Part B. So, for example, physician's fees or diagnostic testings. Part C is the admission and bills, both. So, parts A plus B, so combo. C for combo. Delivered by approved private companies. And then you have part D for drugs or prescriptions. Okay, so these are the parts for Medicare. So Medicare has these four things in it. So admissions and skilled nursing, they take care of that. They take care of basic medical bills. They take care of both of these things as well together, approved by private companies, and then also for the drugs. They take care of that as well. What is palliative care? It's the medical care aiming to provide comfort, relieve suffering, and improve quality of life in patients with serious illness, regardless of their diagnosis or prognosis. Okay, so often concurrent with curative or life prolonging treatment. So this is where you just try to make them feel good or better, right? Delivered by interdisciplinary team, physicians, nurses, social workers in hospital, outpatient clinic, and at home. So they're gonna ask you a difference. So they're gonna test the knowledge you have on palliative care by confusing you with hospice care. Okay. So what is hospice care? This is the end of life care. It's the form of palliative care for patients with prognosis less than 6 months, when curative or life prolonging treatment is no longer beneficial. So when it's someone that's terminal, they would receive hospice care, not palliative care. Okay. Even though hospice care is part of a form of palliative care, but yeah. Common cause of death in U.S. by age. So in babies, it's gonna be congenital malformations, preterm birth, or sudden unexpected infant death. Unintentional injuries from age 1 to 44. Okay, that's going to be number 1. Then we have CSC, so that's cancer, suicide, and cancer. Congenital malformation, homicide, heart disease. So it's hard to remember all these. Do remember it for this one though. for the babies. So congenital malformations, it's easy to remember because babies who are born with malformations usually die quickly, right? Then preterm birth is the second cause, and then sudden unexpected infant death. Remember it for 45 to 64 and 65 plus, these two. These are not going to be tested on that much. It's going to be more than 60-year-olds. So cancer for this, heart disease, and then unintentional injury. And here, obviously, heart disease is number one cause in elderlies, or like 65 plus, and then you have cancer and also chronic lower respiratory disease as your third most common cause of death in 65 plus. Okay, and then public health sciences, quality and safety. This is an important topic. They test you on every single one of these things. Okay. So safety culture, organizational environment in which everyone can freely bring up safety concerns without fear of penalty, right? That's the safety culture. Then you have human factors design. So forcing functions, those that prevent undesirable actions, for example, connecting feeding syringe to IV tubing, are the most effective. Standardization improves process reliability, for example, clinical pathways, guidelines, and checklists. Simplification reduces wasteful activities, for example, consolidating electronic medical records. So, that's a good thing. Deficient designs hinder workflow and lead to staff workarounds that bypass safety features. For example, patient ID barcodes affixed to computers due to unreadable wristbands. Right, so that kind of hinders the workflow. So you have a PDSA, or plan, do, study, and act. So plan, do, study, and act. So PDSA. Okay, so this is a process improvement model to test changes in real clinical settings. So they have an impact on patients, right? So plan, so define problem and solution. Then do, so test the new process. Then measure and analyze the data and study. And act as integrate new process into workflow. So first, you see what the problem is, and then you see if the new process, the solutions work or not in do. Then you see how well it worked or what the difference is and all that stuff in study. And then you implement it to the whole hospital or all the departments. And so integrate new process into workflow. Quality measurements. So measure, example, structural, physical equipments, resources, facilities, number of diabetes educators, right? This is an important thing for diabetes, because people with diabetes don't really understand the disease. They just think that they gotta go on diet and work out, that's it, you know. And normally you would get results with like that as well, but education really helps and understand it, and you know, it takes out the fear from it. Process, performance of system as planned, percentage of patients with diabetes whose HbA1c was measured in the past 6 months. Right? Outcome, impact on patients. Average HbA1c of patients with diabetes. And then you have balancing, which is impact on other systems and outcomes, incidence of hypoglycemia among patients who tried an intervention to lower HbA1c. Okay, so this is quality measurements. I don't remember any questions that had this in it, so I lied, I guess. not everything is important in this. So you can probably just read that and just keep it in the back of your head. Swiss cheese model. This is a really important one. They'll give you like a few scenarios where they're questioning your knowledge on Swiss cheese model. So focuses on systems and conditions rather than an individual's error, right? So there's just there was a problem in this part of the whole treatment for the patient, and then there was a problem here, and a problem here, and then what happened was the hazard that started over here, and all of that led up to the harm. Okay, so what that means is these were the defense strategies, and there were loopholes or like potholes or like holes in the whole system. So something went through it. So it focused on systems and conditions rather than an individual's error. The risk of a threat becoming a reality is mitigated by differing layers and types of defenses. Patient harm can occur despite multiple safeguards when the holes are in the cheese. The holes in the cheese line up, right? So the holes are potential failures in the defense strategies. Okay, and that's how the harm happened. So say, I don't know, for example, a patient was due to have his left leg amputated, okay, and then his right one got amputated instead of the left. So the holes were like maybe when the nurse picked up the file, she didn't notice it, and then she handed it to the head nurse and she didn't notice it, and then it wasn't confirmed by the head nurse, and then she put the file on the doctor's table, and then doctor came in with the file, he didn't notice it, and something like that. So nobody throughout the handling of the file noticed the difference, and no one asked the patient either, so that would be a hole as well. So the way you would fix this is you have the head nurse make sure that it's the right leg, you have the doctor make sure it's the right leg, maybe you have another person as well, right? Something like that. So types of medical errors may involve patient identification, diagnosis, monitoring, healthcare associated infections, medication, procedure, devices, documentation, handoffs. Medical errors should be disclosed to patients independent of immediate outcome, right? Even if it's harmful or not. Okay. So an active error is it occurs at a level of frontline operator, for example, wrong IV pump dose programmed. Okay, so that's active error. So immediate impact. Then you have a latent error, which occurs in processes indirect from operator but impacts patient care. For example, different types of IV pumps used within same hospital. So it's an accident waiting to happen, right? Never event, which is an adverse event that is identifiable, serious, and usually preventable. For example, scalpel retained in a surgical patient's abdomen. Right? This is something that never should happen, right? So that's a never event, and it rarely happens, I guess. So that's why it's a never event as well. Okay, so this is a latent error is an accident to happen. Active error is one with the immediate impact. So never event, major errors that should never occur. Sentinel event, a never event that leads to death, permanent harm, or severe temporary harm. Okay, and then you have a near miss. Unplanned events that does not result in harm but has the potential to do so. For example, pharmacist recognizes a medication interaction and cancels the order. Okay, so narrow prevention of harm that exposes dangers. Okay, you have a question about say an intern figured out a problem with the patient's file, and before the doctor went in for the surgery, uh, they fixed it. Okay, it's something that the patient wouldn't have known about. It's not something the patient would, it would have impacted the patient or something like that. you know so what do? Do you still tell the patient or not? Apparently you do. uh, you're supposed to tell the patient even though it doesn't affect them, and even though it wasn't harmful, you still tell the patient that this has happened, and uh, we took care of it, and this we made sure that it never happens again to any other patients. Okay, so you tell them. Also, transparency. It actually, lowers the amount of cases against doctors and hospitals. So burnout versus fatigue. Burnout, prolonged excessive stress. So this can lead to medical errors due to reduced professional efficacy. Okay. And then there's fatigue, which is sleep and rest deprivation. This can lead to medical errors due to cognitive impairment. Okay. Then you have medical error analysis. This is root cause analysis, so retrospective approach. So a problem has occurred, right? And then you got to figure out what happened. So the root cause analysis is a retrospective approach applied after failure event to prevent recurrence. Okay, so you figure out why a problem happened by going through each and every step of, like the file thing. You would go and through each steps of who handled the file, kind of thing. So use the methods you do this with is use records and participant interviews. For example, 5 ways approach: fishbone, cause and effect diagram, process maps, to identify all of the underlying problems. For example, process, people, environment, equipment, material, management that led to an error. Okay. So that's called root cause analysis. So they'll give you a scenario with these things, and they'll tell you what type of approach was this. So it was a root cause analysis. Then you have a failure model and effects analysis. So it's a forward-looking approach, so applied before process implementation to prevent failure occurrence. So it uses an inductive reasoning to identify all the ways a process might fail, and prioritizes them by their probability of occurrence and impact on patients. So this would be like, right now I can just think of it's non-hospital scenario. How with the shooting in Texas, they're now planting a door stopper behind doors, right? But I guess the problem already happened, but they're anticipating another one, so that's what it's for. I don't have a analogy for this, but that's pretty straightforward to understand. They'll give you that a problem hasn't occurred, but they're preparing for, a wide crowd and a stampede or something in the hospital. I don't know. And that would be a failure mode and effects analysis type approach. And that's it. You're done.